Many men may recall when their father or another family member had underwent the Roto-Rooter procedure for their enlarged prostate. Today, we are going to learn more about the procedure that has long been a mainstay in the treatment of an enlarged prostate, the TURP, Transurethral Resection of the prostate, including the evolution of technology used for the procedure and who might still be a candidate for this therapy. We have board-certified urologist Dr. Jon Morton joining us today, an expert when it comes to the management of an enlarged prostate. So stay tuned. So the big question is this: how can men and those who care for them better educate themselves regarding prostate health, the conditions that affect the prostate, and the latest technology in managing these conditions? That is the question, and this podcast will provide the answers. On a weekly basis, we will be chatting with experts, innovators, and leaders in the field of urology, sharing useful information with the general public to improve their lives and increase their overall health. My name is Dr. Garrett Pullman, and welcome to the Prostate Health Podcast. Prostate Health Podcast is for informational purposes only. Nothing in this podcast should be construed as medical advice. By listening to the podcast, no physician-patient relationship has been formed. For more information and counseling, you must contact your personal physician or urologist with questions about your unique situation. It is a pleasure to have joining us today on the Prostate Health Podcast board-certified urologist Dr. Jon Morton from Omaha, Nebraska. Dr. Morton completed his urology residency training at the University of Nebraska Medical Center in 1994. His practice, the Urology Center PC, is comprised of 11 urologists who help in providing expert urologic care to the greater Omaha area and surrounding communities. I've known Dr. Morton now for close to 10 years. He continues to remain a leader in our region when it comes to advanced urologic procedures, including minimally invasive therapy for BPH or prostate enlargement and prostate cancer. He has also had the opportunity to continue to help in training future surgeons through the University of Nebraska Medical Center's Urology Residency Training Program. I'm excited to have him here today to share his knowledge with our listeners. Dr. Morton, welcome to the Prostate Health Podcast.
Thank you, Dr. Pullman. Appreciate the opportunity to participate in your podcast. I hope you and family are safe.
Thank you. Well, Dr. Morton, so how can enlargement of the prostate or BPH interfere with normal urination?
That's a great question. I tend to grapple with that a lot because you and I, actually almost every urologist that's ever been in practice probably is somewhat frustrated with the patient that has very significant voiding symptoms, but not a real large prostate or what you and I would describe as a middle lobe obstruction. And I can go into that later if you want. But I try to educate patients that not everybody's the same. You can actually have enormous prostates, 3, 4, 5, 6 times normal with minimal complaints, or relatively medium-sized prostates and terrible complaints as far as voiding. But the biggest issue you and I run into is patient education for future safety and other health concerns, such as the urine backing up to the kidneys and run into renal problems and renal failure, and the dreaded dialysis patient that has no urinary symptoms but shows up in basically urinary retention. So,
and again, what are some of the more common symptoms that you're hearing from men that are coming to see you with their prostate enlargement?
I've heard the term Roto-Rooter surgery, or I had a patient from southwestern Iowa ask me the other day, are you going to do that auger thing you did on my brother? And I had to giggle because I'm a city boy. I grew up in Omaha and I never knew what an auger was. But basically I describe it as, in lay terms, grandpa's disease or obstruction of the bladder from an enlarged prostate. And generally what we try to do, if we can understand the concept, is to try to open that channel up so the patient can pee more freely and get rid of some of those frustrating grandpa symptoms, the urgency, the frequency, the nighttime urination. And then there's some of the signs that you and I see are, I think, also critically important that people don't ignore, and making sure that we get the word out to the primary care providers. If someone shows up with blood in their urine, or they develop symptoms or signs of bladder obstruction, such as bladder stones or some of that pathology that you and I see on a daily basis.
Well, so far on the Prostate Health Podcast, we've discussed various different treatment options for men with bothersome symptoms from their enlarged prostate. Now, one treatment option that we have not yet really featured on the podcast is, again, one that's been considered the gold standard for decades, the TURP procedure. And you kind of alluded to this with the auger Roto-Rooter procedure. Can you first describe to our listeners, what is a TURP?
Yeah, as a matter of fact, that's part of the biggest downfalls of the education is that patients that have had a TURP before, especially with the old technology back last century and even the early part of this century, the patients that have had a TURP sometimes get the impression that their prostate's been removed. And all you and I are doing with a TURP is just basically removing anywhere from 10 to 30 or 40% at the most of the middle part of the prostate, the middle part that causes the blockage. Histology wise, the prostate is an organ of reproduction. It's important for its glandular function and some of the seminal fluids that we provide when we're fathering children. The biggest issue we see with the gland that increases in size is the middle part of the prostate that causes that obstruction. You and I describe it as the transitional zone.
So now men are continuing to have an increasing number of minimally invasive options available to manage their BPH, such as UroLift, Resume. Do you feel that the TURP procedure still has a role in managing men with an enlarged prostate?
Absolutely. I'm going to be showing my age here, but I was involved with some of the original minimally invasive techniques, such as a balloon dilation of the prostate. When I was a resident over at the VA, we actually had a study group where we would actually do a balloon dilation, just like people would comprehend as far as putting a balloon in and dilating the artery for blockage of a coronary artery. But we had a much larger balloon dilate the prostate, and then the other patients we would do a placebo effect where we examine the prostate and the bladder and then just monitor them. And interestingly, many patients that had the balloon and many patients that had nothing similarly reported outcomes. And I joked with some of our colleagues at the time that I think we were relieving the evil spirits from the bladder and the patient's symptoms were getting better. But it's hard, it really is. And some of the things that evolved from that study have led to the TUMT, the microwave of the prostate. All of us men in my age group in the 50s and 60s and even 70s are seeing these advertisements for the steam therapy. And I've used multiple different lasers over the years. There was a green light laser, there was a blue light laser, the Revelex laser, and I've kind of adapted what I would consider probably the most recent state-of-the-art laser if a patient wants to go that direction. That's the thulium laser. It's just a different wavelength, a different form of energy to vaporize the tissue, and so I use the thulium laser. It's also, in lay terms, called the cyber-TM laser of the prostate. But basically, anything that you and I can do with technology to try to vaporize the tissue to open that channel and safely do it is available to patients nowadays.
So what initial tests could a man expect, during his initial evaluation with his urologist and really kind of determining maybe what might be the best option for him?
That's a great question. Many of the tests may have already been done before they even seek attention from a specialist. I think that's actually very reasonable. Sometimes they evaluate the upper tracts, what you and I call the upper tracts. They evaluate the kidneys and they do an ultrasound of the kidneys or something along those lines. And the ultrasound sometimes will encompass or involve the pelvis, and then within the pelvis you'll see ultrasound of the bladder, so that patients get what we call as a post-void residual. In other words, how much do you have left over in your bladder after you're done voiding? So a post-void residual, I think, is something that's pretty much standard for all patients seeking attention or treatment for suspected prostate enlargement or BPH symptoms. I actually rely a lot on the flexible cystoscopy. I joke with my patients that you'll see the bank robbers on TV use a telescope to look around corners, and people, can identify with that. But I feel, and I suspect you would agree, most urologists agree, that the cystoscopy has a huge role to play in it. So if a patient comes to me with symptoms and they have an elevated post-void residual, or the doctor has tried some of the medical therapy, which we can go into as well, that's available, then I would usually recommend a cystoscopy before they make any decisions on treatment options, kind of a reconnaissance mission, for lack of a better term, to kind of visualize it. And then when you're there, you and I can measure the prostate, see how big it is, the volume of the prostate, that kind of information.
And I think it's great too. And as you found out as well, just not only prostate, but also kind of the state of the bladder too, and maybe get a sense of kind of how far along in the process they are, seeing some of these changes in the bladder.
Excellent point. You are quite a bit younger than me, and I actually had the opportunity to train when I was at the University of Nebraska with a world-class pathologist who actually was involved with some of the Scandinavian studies where they would biopsy the bladder and look at the health of the fibers, and they were making judgments at that time. Nowadays, you and I are looking in the bladder with our telescope, and basically we can give patients a little bit of a futuristic picture of what they might see if the bladder continues to undergo deterioration. So that's an excellent point.
So how has the transurethral resection of prostate procedure, or TURP procedure, kind of evolved over the years?
I was actually involved back in the day when the urologist, I joke about being a short, fat, bald urologist, but I actually trained under one of the nicest gentlemen at the University of Iowa that actually would allow us to take a few scoops of the prostate with our electrical current, the monopolar equipment, and then he would look in and say, well, that's pretty good, John. You need to be a little bit more aggressive and take a few other bites of this. And so basically the technology has radically changed. Residents now, everything's done on a video camera. You and I are watching it and monitoring them, and we're actually getting instant feedback. And so you can watch procedures and operations and TURP procedures through video broadcast and learn a lot before you ever embark on your own career. And so I was one of the first doctors from the med center that would go out in the community and demand a camera for the patient when I did a TURP, and I'd get some sideways looks from the surgical scrub nurses. But it makes a huge difference. The visualization's better. That you mentioned, the technology has come up. We've switched from a monopolar TURP to a bipolar TURP, and from the lay term, that's probably not that big a deal, but it's much safer for the patient. The anesthesiologist used to do spinal anesthesia so they could monitor the patient's coherency and communicate with them to make sure they weren't having a drop in their sodium and have what's called a TURP syndrome, where the patient's mental status would change because they were absorbing a lot of the fluid from the old glycine that we used to use. For basically safety purposes now, almost every TURP is done with what we call the TURS, or the Transurethral Resection in saline, and it's amazingly safer. It really is.
Certainly it's, very, happy to have those advances. And in my training, I kind of just caught the tail part of it, seeing some of the monopolar TURPs, but it certainly it really does help, to have that newer technology and advancing our care for these men. So now when counseling men about TURP procedure, what kind of results can a man expect from the procedure?
I do spend a lot of time explaining the difference between some of the minimally invasive procedures, such as this UroLift that you and I are both doing for patients, and trying to explain to them that with some of the minimally invasive procedures, we're kind of pulling the curtain back on the prostate and opening the channel, or the anterior channel of the prostate, as you and I call it, to try to allow them to void much more efficiently, improve it, but not mess with their sexual function. And in general, I hope you agree with me that I do try to explain to patients that the procedures we're doing on patients are men in their 50s, 60s, 70s, and 80s, and sexual function does remain an important part of the situation. But I've not seen any of the minimally invasive procedures or the TUR procedures cause direct impotence or inability to get an erection if a patient had that before the surgery. So I try to reassure them with that. That said, the biggest thing we see with a successful medical therapy for BPH or successful TURP is what we call retrograde ejaculation. And you can Google that, and basically when you have relations, you don't see the semen come out normally. The patient still has normal sexual function, erections, and ejaculation, but when they void the very next time, the semen's mostly in the urine, and they void it out rather than have a normal ejaculatory event that they have come to know when they were younger. So I hope that explains quite a bit to the podcast audience.
And I think that's something that does come up with men from time to time that are still looking to preserve that ejaculatory function, and with some of the newer procedures like the UroLift, which help preserve that function. But some men may not be, because of their prostate anatomy, big intravesical or median lobe might not be a candidate for the UroLift if we can't pin that tissue over. For those men, that are requiring a TURP procedure, have there been some options that you've been able to utilize to help still preserve that ejaculatory function? Oh,
sure. One of the things that I've tried over the last maybe decade or so for selected patients, if you have a distinct conversation with them about the risks of having to have maybe more than one or two procedures. Going back even further, some of the medical therapy that you and I've used over the years can cause retrograde ejaculation and problems with that. And in general, some men with just an enlarged prostate will see a decrease in their semen. So I spend quite a bit of time with them. You won't remember this, but we kind of stole one of the internal medicine medications, Minipress or Prazosin, which was a blood pressure medicine. And those blood pressure medicines evolved, and now they have what you and I describe as uroselective alpha blockers. So alpha blocker therapy is one of the medical treatments we have, but if you have many alpha blocker therapy drugs that are available, you have to explain to patients they might see the retrograde ejaculation. So I talk to them about possibly getting off the medications that cause that or staying away from the standard TURP that will result in a good stream, but retrograde ejaculation. And sometimes if I do a flexible cystoscopy, as you and I mentioned, and I see that the middle lobe of the prostate kind of flops down almost like a flapper valve on a toilet seat, is for lack of a better description. If I see that middle lobe flopping down, sometimes I'll talk to a patient about doing a TUR of just that middle lobe or lasering that off the part of the prostate that's growing up into the bladder, and then monitoring their symptoms, adding a possible urolift down the road or trying to get off medications and just seeing how they're doing to try to preserve that antegrade ejaculation. So
that's great. So if men were taking prostate medication before the procedure, are you typically able to get them off of this medication afterwards?
That would be the goal. I try to educate patients because we've seen an evolution to, about 4 different options for quote unquote medical therapy. And people most of the time have heard about Flomax or Tamsulos. And if you and I were to develop or design a medical therapy to try to help men pee better, we'd name it probably, Morton, Pullman, Flomax too. But basically Flomax was the mainstay of therapy for many, many years. And then the drug that I believe is truly a game changer with prostate growth and prostate enlargement is finasteride or dutasteride, also known as Proscar. I tell patients that the Flomax is kind of a relaxer for the alpha blockers in the channel to try to help them flow better, but it doesn't shrink the prostate. The second drug that I mentioned, the finasteride or dutasteride, is an amazing medical therapy that I like because it does shrink the prostate. It reverses the process. It treats the disease, but I tend to not use it in men that are sexually active because they yell at me, probably like they do in your practice. They yell at you they claim that it causes sexual dysfunction. I mean, the studies suggest only about 5% of men will have a decreased libido or affected sexual function. But I think if you plant that seed, it'll affect it a lot. There's a third class of drugs that you and I have used over the years. I describe them as overactive bladder medicines or OAB medicines, and we use them in children that are having issues with frequency and urgency. We use them in ladies that have overactive bladder. We use them in men sometimes to try to get them a little bit better sleep at night as far as treating the bladder to reduce that urgency and nocturia or nighttime urination we see. And then probably the thing that's really changed in the last 5 or 6 years is the generic form of Cialis. Cialis has been known as a erectile dysfunction medical therapy, and you and I are familiar with that because of that part of our practice. But a lot of folks don't realize is that when Lilly Icos released Cialis, they actually said, what are we going to do with this medical therapy for erections that sticks around for a day and a half? So they lowered the dose, gave it to men every day. It did sometimes cause a hole in their wallet because it cost so much for a month's supply, but basically the people that took that daily Cialis or tadalafil, as you and I know it as the generic form, they actually said, hey, I'm peeing better. So you and I have 4 different medical therapies that we can institute and talk with patients about. And many of our patients coming from the internal medicine or the primary care doctor are already on some of these medicines. And so you and I'll add the cystoscopy and sort of wrap it all up in a bow and tell the patients, okay, this is how big your prostate is. This is what your options for treatment are. You can stay on the same therapy. You can, as you just mentioned at the beginning of this question, sorry about being so long-winded, but you said, hey, do you want to try some of these things so you can get rid of some of the pills that you're on? So,
and I think that kind of starting to see a little bit of a, especially with some of the less invasive approaches, men are maybe kind of looking now to get off their medications or maybe avoid the side effects altogether. But for those men that do require a TURP procedure, what can they expect in terms of recovery after that procedure?
I tell them that the big difference with the TURP procedures is generally we need the technology that's in the hospital, and they should expect an overnight stay. All of our patients in this world, especially our men over the ages of 50 and 60, they want to do drive-through surgery. You come in the hospital, get it done, and go home. And you really can't do that if you do a TURP properly. I tend to tell them, plan on 24 hours in the hospital, plan on a continuous bladder irrigation, fancy doctor term for a catheter that has fluid running through it so that the nurses don't have to irrigate it out for the expected mild blood in the urine postoperatively. And I did a procedure last night that it was actually almost a 2-hour procedure on a patient that actually had a urolift, and he just had a very big prostate. And so I went ahead and did the TURP, and he's getting his catheter out this morning. He's going home from the hospital, and hopefully he'll go home without a catheter and do well, but it requires an overnight stay, and then he's going to need about 10 to 14 days of trying to stay off his blood thinners and aspirin if he has blood in the urine. If it's clear and he sails, he can go on all of his medicines afterwards. And I think you'll probably back me up on this. We don't see a lot of postoperative discomfort or pain. Patients do really, really well. We rarely send them home in the hospital with anything stronger than Tylenol or Advil. And then our goal would be to get them off some of those medications that we talked about, the Flomax or the finasteride or the shrinker. So,
well, lastly, another question men have is, how long is this procedure good for? Is most men just pretty much need one of these in their lifetime, or?
Great question. I was in the preoperative area of a gentleman whose daughter and my wife went to high school, 40 some years ago together. And I said, Bob, it looks to me like I did this TURP on you about 15 years ago. I must not have done a very good job. And he said, nope, doctor, you told me that if I live long enough that I probably would need this again. And so it does resonate that maybe at least 15 years ago, I told the patient the proper information that it's a very good procedure. It's the procedure that he and I have chosen together. But as the prostate grows back, he may need a second look or a repeat treatment. So.
Well, you've really given an excellent overview of the TURP procedure, which, again, continues to remain a viable option for select men suffering from an enlarged prostate. So, Dr. Morton, any final thoughts today for our podcast listeners?
Education. We're in a tough world right now. Here we are looking at each other hundreds of miles away and chatting with the folks that are listening and learning, but it's a fabulous world, but you can get overrun with information. And I think it's important to make sure the patient tries to schedule time to talk with their physician, communicate with their primary care physician what their goals and information is, and try not to go into a situation where they're setting themselves up for failure. And that's key. And all of us need, a few more hours in the day and a few more days in the week so we can properly talk to patients. But education's out there. You can unfortunately get some really good information on the internet, and you can unfortunately get some really bad information on the internet. Be very wary of people trying to sell you one particular procedure. Probably the best words of advice I ever got from my father, God rest his soul, was he said, son, when there's a lot of different ways to solve a problem, there's probably not one perfect way. And I think that's where this situation comes in. There's a lot of good ways to treat BPH. I think you'll agree, but there's not one perfect way, and everybody's a little bit different. So.
Well, Dr. Morton, we really appreciate you taking time to join us on the show today. You've definitely given our listeners some valuable information, which will really help empower them as they learn more about their prostate health. So thank you again.
Oh, you're welcome. Pleasure to be here.
Thank you again for listening to the Prostate Health Podcast. We would love to have you join our podcast Facebook group at www.facebook.com/groups/prostate health podcast, or just use the Facebook group search function and search for the Prostate Health Podcast and ask to join. We'll see you at the next episode.